احنا المره اللي فاتت اتكلمنا على إيه، ماشي. المره اللي فاتت اتكلمنا على الهيمسفيريك برزنتيشن والفيجوال باثواي برزنتيشن. دول كان التو مين سيشنز بتوع المره اللي فاتت، وزي ما اتفقنا هتلاقيهم موجودين على البلاي ليست على اليوتيوب شانل. المره دي هنتكلم على البرين ستيم، وهنتكلم على السباينال كورد. وبما ان ديت بالتعريف السيشن دي بالتعريف هي ليها علاقه بالادفانسد براكتس. يعني هي مش بتشرح الاساسيات قوي قد ما هي بتشرح انت يعني خطوه زياده عليهم، يعني بتزود كلمتين زياده على اللي انت تعرفه اوريدي. اللي انت تعرفه ده اللي هو ان انت ازاي عارف تشخص ام اس، وعارف الايديال الايدنتيفيكيشن بتاع الام اس ليجنز عم باينه ازاي في البرين ستيم وفي السباينال كورد، طبعا فضلا عن البرين والفيجوال باث ويز اللي هم في السيشن اللي فاتت. فاحنا المره دي السيشن دي هنتكلم على البرين ستيم، والسيشن اللي بعديها هنتكلم على السباينال كورد. بالنسبه للبرين ستيم معظم الوقت احنا مش هنشوف ليجنز خالص. معظم الوقت احنا هنراجع مع بعض الاستراكشرال والفانكشنال اناتومي اللي احنا متوقعينه في البرين ستيم. بس هنحاول نطبق اللي هي اللاند ماركس، الحاجات اللي احنا عارفينها، عارفين ان في ريدي نيوكليس، عارفين ان في سبستانشال نيجرا، عارفين ان في بالبر نيوكلياي. الكلام دوت هنحاول نحطه على الاستراكشرال اناتومي بتاع الاستراكشرال كروس سكشنال اناتومي، اللي هو الاستراكشرال اناتومي اللي هو الشكل العادي، ولكن على اللي هو بالتحديد على الاكسيال كاتس مثلا اللي احنا بنشوفها في الاشعه. وده اللي هنستخدمه بشكل اساسي. وبعدين في الثلث الاخير، يعني ده هيستهلك معظم الوقت في السيشن ديت. وبعد كده في الاخر هنلاقي نبتدي نحط بقى ليجنز بتاعت البرين ستيم، بتاعت الام اس ازاي بيظهر في البرين ستيم، ولاي مدى بيطلع انهي سيمبل. مش كل ليجن بيطلع في الاشعه بيطلع نفس السيمبل. في ليجنز اريتيتيف، في ليجنز ديستركتيف، في ليجنز سايلنت. فكل مرض السبروك بيطلع باترن اللي هم السبروك سندرومز المشهورين، ويبر وبنديكت وكوبلر والكلام دوت. وهتلاقي بعد كده الام اس ليجن ما اتوصفتش بالطريقه ديت، بس هو هدف، انا دي وجهه نظري الشخصيه او دي فلسفتي الخاصه يعني في فهم الام اس. هتلاقي في كلينيكال راديولوجيكال سندرومز واضحه وكونسيستنت جوه البرين ستيم خاصه بالام اس، ما بتصلح مش بتحصل بنفس الباترن دوت مع امراض اخرى يعني. آه و وبعد كده في برضه في نمط معين وفي توزيع معين للاشعه للليجنز جوه البرين ستيم بيحصل مع الام اس ليجنز وما بيحصلش مع اي حاجه تانيه. آه، ف فمهم ان انت وانت بتطلب، لو انت شاكك ان العيان بتاعك عنده اي برين ستيم برزنتيشن وانت شاكك ان هو حاجه انفلاماتوري، مهم ان انت تطلب هاي فيلد سكانر. ما لا تضيع وقتك ولا فلوس العيان على اوبن ام ار اي ولا الكلام دوت. لازم هاي فيلد سكانر. لازم عندك اثنين تي 2 ويتد سيكونسز، اللي هو تي 2 العادي زائد فلير. دول على الاقل. الفلير تي 2 ويتد اسمه كده، يعني هو تي 2 ويتد بس احنا عدلنا عليه وشلنا منه السيجنال بتاعت الميه، فهو ايه، فاسمه تي 2 ويتد. ولازم تبص كويس على ال تو ديفرنت اناتوميكال بلينز. يعني انت محتاج لو الليجن حجمه كبير، بالذات حجمه كبير، لازم تبص في اكتر من، مش الاكزيال بس، تبص على الاكزيال كورونال، اكزيال ساجيتال، زي ما يكون متيسر معاك بالنسبه للفحص. فور اور اون بيربزز احنا هنقسم البرين ستيم للثلاث مناطق المشهورين: ميد برين، بونز، ميدالو. ثم هنقسم كل منطقه لابر ولور، يعني ابر ميد برين، لور ميد برين، ابر بونز، لور بونز، ابر ميدالا، لور ميدالا. كل واحده من دول ليها لاند مارك على الاشعه، ليها لاند مارك، اناتوميكال لاند مارك تقدر تفهم من خلالها ان انت في هذه المنطقه. ليه التقسيمه دي مهمه؟ ليه الليفل مهم؟ لان الليفل ليه علاقه بالاستراكشرز اللي موجوده في البلين دوت، وليه علاقه بالتبعيه يبقى ليه علاقه بين الليجن واخد ايه او مأثر على انهي تراكت او انهي نيوكليس، فتستنى انهي سيمتوم. وفي الاخر توصل بالاستنتاج بتاعك، هل الانترنيوكلير ليجن اللي انا شايفها ديت متفسره من الميد برين ليجن دوت، ولا البونز كونتاين ليجن دوت، ولا ده كوينسيدنس، ولا ده مش متفسره وفي حاجه ثانيه ناقصه وكده يعني. تمام، تعال نبتدي بالميد برين. ميد برين تو ليفلز. هعرف منين انه ابر ميد برين ولا لور ميد برين؟ معظم الميد برين اصلا ما فيهوش كرينيال نيرفز، ما فيهوش نيوكلياي. معظمه هتلاقيه واخد السيريبرال بيدانكل، واخد المنطقه بتاعت البرين نيوكليس والسيريبيلر ديكاستيشن، وما فيهوش خالص برين ستيم نيوكلياي ولا بتاع. وعلامته ان انت دايما طول ما انت شايف السيريبرال اكودكت، طول ما انت في منطقه الميد برين، الابر ميد برين. اللور بارت اوف ذا ميد برين اللي هي المنطقه اللي انت شايفينها ديت، اللور بارت ده بيحصل ايه؟ بيحصل ان الاكودكت خلصت، وابتدى يبان الابر بارت اوف ذا فورث فنتركل اللي هي المنطقه ديت. فطول ما في اكودكت يبقى احنا فين في المنطقه بتاعت الميد برين، ابر ميد برين. طول اول لما تخلص يبقى احنا لور ميد برين. والميد برين شكله في الاشعه مشهور من ايام ما كنت بتدرب في النيابه من زمان، اللي هو كان ايه، يقول لك شبه الشورت المقلوب او شبه ميكي ماوس. ده احنا هنا دي احنا بادئين من فوق خالص، طبعا دي الثالاموس. وبعدين دي اللي خلصنا الثالاموس دي تحتيها الليفل اللي تحته على طول. فده اللي هو ابتدى يبان ان ده اخر حاجه خالص في الثيرد فنتريكل، وابتدى الثالاموس اختفت، فيبقى دي المنطقه بتاعت السب ثالاموس، ودول اللي هم الميديال واللاترال جينيكليت نيوكلياي. والليفل اللي بعد كده على طول هيبقى الابر ميد برين. ودول شكلهم انا يعني كنت في احد المرات اللي بشرح فيها السيشن ديت كنت فاضي، فقعدت الونهم عشان يبقوا شكلهم الماركس بتاعتهم سهل. هنا بقى ايه ده اللي هو الشورت المقلوب دوت او ميكي ماوس، هو ده ده الشكل الطبيعي بتاع الميد برين. معظمه ما فيهوش زي ما اتفقنا، الابر بارت ده ما فيهوش اصلا، ما فيهوش نيوكلياي الا النيوكليس بتاعت الثيرد نيوكلير كومبلكس، عاده بتبقى قدام المنطقه بتاعت الاكودكت. فهو ايه المناطق، ايه بقى الاستراكشرز المفروض اللي هي هتلاقيها في المنطقه ديت؟ هتلاقي قدام خالص خالص ده اللي هو ايه اسمه البيراميدال اللي هي الديسندنج فايبر، بروجيكتنج فايبرز، اللي هي طالعه من اصلا. لو انت طلعت ليفل فوق ده، لو انت طلعت شويه فوق الحته ديت، هي دي هتلاقي ان هي كانت نفس المنطقه بتاعت الانترنال كبسول. فهي الفايبرز اللي نازله فوق من الموتور سنسوري موتور ستريبس، وهي نازله تحت عشان توصل للسباينال كورد وتوصل للانتيرون هورن سيل وللبرين ستيم نيوكليا. هتلاقيها ماسكه فين؟ ماشيه قدام خالص. ولو انت فاكر كمان برضو التقسيمه بتاعت الانترنال كبسول تقريبا شكلها عامل كده، كان قدام بري فرونتال، وبعدين بتقول انها بيراميدال، وبعدين تقول سنسوري، وبعدين تقول فيجوال. طبعا فيجوال خلاص الله يرحمه فوق في البرين. فانت المنطقه اللي هي اللي قدام دي اللي هي البيراميدال، المنطقه بتاعت البروجيكشن فايبرز. اللي هي بروجيكشن فايبرز يعني فين؟ يعني ايه؟ يعني جايه من البرين من فوق ونازله تحت على اللور سنترز. فده بروجيكشن فايبرز. وهتلاقي تكملتها بقى كده الانترستنج، ان انت لو يعني لو هحط الانالوجي ده، المنطقه دي هي منطقه السنسوري تراكتس اصلا. يعني هتلاقي بقى الايه، لاترال لمنسكس، ميديال لمنسكس، مش عارف الكلام اللي هو اللي بيطلع على الثالموس دوت، يمسك في الاخر يعمل ريلي في الثالموس، هو ماسك المنطقه ديت. وهو الارينجمنت بتاعه عامل زي علامه اكبر من واصغر من كده، زي ما كانت موجوده في الانترنال كبسول. فهم يعني موجودين ميكينج سنس، يعني هو الارينجمنت ده ميكينج سنس. ايه زياده على كده؟ في اكودكت، احنا عرفنا انه ابر ميد برين عشان هو اكودكت، فده اوكي ويل اند جود. بس في كمان بقى ايه يعني، في شويه ستراكشرز ثانيه احنا حافظينهم بالاسم. ورا البيراميدال على طول، ورا البيراميدال بروجيكشن فايبرز على طول، سيجنال منطقه كده ليها سيجنال مختلف. بس لو شفتها حتى في الفلير هنا تبص تلاقيها ليها هايبر انتنسيتي شويه مختلفه عن الهايبر عن الهايبو انتنسيتي اللي هنا. خليني اشيل ماركينجز وتبص عليها تاني. ده بيراميدال، ده ديسندنج فايبرز، ودي سبستانشال نيجرا. اللي ما شافش سبستانشال نيجرا قبل كده ويعرفها بالاسم بالايميلات، ادي سبستانشال نيجرا، هي دي سبستانشال نيجرا. طب ايه اللي ورا سبستانشال نيجرا؟ رينيوكليس. شكلها برضو لا يخطئ، اللي هو هتلاقي فيها قريتين كبار كده وهايبو انتنس لان فيهم ايرون. هي اسمها رينيوكليس عشان كان فيها، هي فيها الايرون الفيزيولوجيكالي كونتيننج ايرون. فهي فيها، فبتبان شكلها مور هايبو انتنس عن الباقي. فهم الثلاثه دول ورا بعض من قدام لورا، descending fibers substantia nigra red nucleus. اتبقى لنا بقى ايه؟ اتبقى لنا، انت عارف ان في سيريبيلر ديكاسيشن بيحصل، سوبيرور سيريبيلر ديكاسيشن بيحصل فين؟ بيحصل في المنطقه اللي ورا الرينيوكليس. ولهذا حكمه يعني لما نيجي بقى للام اس هيبان لك الكلام ده مهم يعني. سوبيرور سيريبيلر ديكاسيشن. ثم احنا عارفين برضو ان حوالين الاكودكت حاجه اسمها بيري اكودكتال جراي. البيري اكودكتال جراي اكيد هيبقى حوالين البيري الاكودكت. آم، آم، آه، ف ف فاحنا فدي منطقه. وبعدين ما بينهم اللي هو ايه، الثيرد نيوكلير كومبلكس. سوري. آه، آم، okay. I had okay, so okay, we have few participants in who are non-Arabic speakers. I will shift back and forth. I will shift back and forth for the main points. I'm going to switch to English, and for the other parts, I'm going to maybe you might hear some Arabic jargon when my brain is on the on the flight mode. So to recap again, that's the descending projecting fibers, substantia nigra, brain nucleus, cerebellar decussation, and there is some nuclear, a third nuclear complex here, periaqueductal gray, and then the superior cerebellar peduncle. The landmark of the upper midbrain is the presence of the aqueduct. As you go downwards, in the brainstem, you would find that the aqueduct starts to go back. So it will travel a little back. So it will go in the backwards direction in the posterior part, and that's where it terminates, and the tip of the fourth ventricle starts to appear. Um, so so that's not the upper midbrain anymore. If let me just remind you back with the same that piece of sagittal plane. All that part is upper midbrain. When the aqueduct, when you start to lose a tictal plate, so that's the tictal plate. That's the any brainstem tissue structure behind the aqueduct. That's called the tictal plate. When it fades away, then you are on the fourth ventricle. Then you are on the lower midbrain. Lower midbrain is interesting because you don't have a red nucleus, you don't have a substantia nigra, and you are left with descending fibers, crossing cerebellar fibers, and not particularly interesting for MS, but it is important that you know that the third nuclear fibers travels and exits through the interpeduncular fossa. That's one peduncle, and that's interpeduncular fossa where the two nerves emerge from the outside. And that's an area as well when you expect the medial longitudinal fasciculus be just in close proximity to the upper part of the midbrain, of the lower midbrain. So, and again, the nice motor sensory capsule-like orientation of more than, less than mathematical sign would appear. And in the middle, you have the crossing cerebellar fibers, very in close attachment to the fourth ventricle. You would find the nuclear complexes, and you would find the fourth nuclear complex, because the third nuclear complex is slightly higher, and importantly, you would find the exit of the third nuclear. So of interest also, the fourth cranial nerves emerge from the backwards, and that at that level, and travels around that part of the CSF space. But again, this is not very MS in for our own purpose. So as far as you reach, as you lose these two leggings of the shorts, of the upside down shorts, if you lose that appearance, you are not in a midbrain. So in the next slide, you would find that the brainstem, the ventral surface of the brainstem, starts to look like an apple, a top surface of an apple, and that's pontine midbrain junction. So that's not the midbrain anymore. So we do identify a midbrain with the presence of the peduncles. As far as it terminates, that we are in the pontine midbrain junction. And interestingly, you would need to anticipate the superior cerebellar peduncle here. That's that. If you imagine that as a tooth, that's the crown of the tooth, and that's the root of the tooth. So that root of the tooth is the superior cerebellar peduncle. There are some cerebellar fibers that starts emerge from the cerebellar hemisphere, travels through the superior cerebellar peduncle, crosses to the other side, and travel upwards here to be crossing as well, continue to be up here as well. So it's continue in the cerebellar decussation. So it is very low, in the very lower part of the midbrain. It emerges from the tooth root, and it crosses to the other side. And at that time, so again, if we contemplate the pyramidals, that they are used to be on the surface of the brainstem, now they will be buried downwards. to the core of the midbrain of the pons now. So it was on the surface here. So let's say it's in the color. So it was in the surface here, and just it was buried down. It was buried down by massive cerebellar decussation. That's actually the sum of the fibers of the middle cerebellar peduncle. If we travel a little bit downwards to see here on the pons, these are all tracts, and they need to cross to upwards and downwards and across to the other side as a main cerebellar fiber. And that's why if you had a midbrain that looks skinny, and you had a pons that looks of a belly of a dedicated neurologist who does not exercise well. So so that's why you had that bulging appearance, is because there are massive cerebellar fibers going right, left, and left, right, and these fibers even covers the pyramidal fibers that used to be there. Okay, and yeah. So let's keep that simple. Let's keep it simple as we speak, and as long as you see a fourth ventricle, every immediate structure in adjacence to the fourth ventricle is a gray matter structure. Gray matter structures are the either pontine nuclei or let's say reticular formation, connecting bundles like the medial longitudinal fasciculus and the central tegmental tract. There are lots of crosstalks on a gray matter area, and they are all posterior in attachment to the fourth ventricle. And that's the very famous panda we hear about in the in people with Wilson's disease. So there is a high market hypo-intensity due to copper deposition in the red nucleus, and some hyperintensity across the substance of the midbrain, sparing the pyramidals or the descending fibers. Okay, so that not to spend too much time on the anatomy, so not to lose time. So again, at a time when you see the middle cerebellar peduncle, that's likely you are on the middle part of the pons. The upper part of the pons is that when you still see the toe tooth. If you see the toe tooth, you're still in the upper part. The upper part of the pons is where the trigeminal nerve fascicles emerge from the sides this way. This isn't a slide without the color markings, but this structure, this very nice fibers, are the trigeminal nerve fascicle, and they emerge from the lateral side, backward side of the midbrain upper pons to travel from the posterior fossa to the middle cranial fossa. This is here a Michel's cave where the trigeminal nucleus would be. So that's the third in the upper part of the pons, where you would expect the sawtooth, the superior cerebellar peduncle, you would expect the trigeminal nerve up there. These fibers are the very next to emerge middle cerebellar peduncle. When we reach the middle cerebellar peduncle that's here, you would expect a different set of nerves. You would find on the petrous bone, you would find the internal auditory canal, and you would expect that the facial and the emerging vestibulocochlear also would join from lateral wards. There's another sign also that is nicely you can contemplate. There is a little bulge here and a little bulge here. This is the facial colliculus, and this is where the 6 cranial nerves, hinges around the trigeminal, the facial nerve, and emerges from the ventral surface of the brainstem. And these are the color codings of what's happening. So that's abducens emerging from the ventral surface, and that's the fascicles of the facial nerve and some of the vestibulocochlear nerves, and all the green stuff are the cerebellar fibers. So the pons is packed with cerebellar decussating fibers. And that's your very famous central pontine myelinolysis with a trident sign, because it involves the core of the decussating cerebellar fibers is sparing the pyramidals, sparing the gray matter nuclei. And now to the medulla. If so, again, we have two levels. We have an upper medulla and a lower medulla. We would have, but and just to remind you, in terms of length. So that's if you compare that lens and that lens and that lens. So the medulla is the longest part of the brainstem. So it occupies many slides as long as you have a fourth ventricle, that's upper medulla, and as long as you have a closed fourth ventricle, you have no ventricle at all, then you are, and you find a central canal, you are in a closed medulla. Let's have a look. That's open medulla. There is a fourth ventricle. That's inferior cerebellar peduncle. Inferior cerebellar peduncle. Let's have the color marks. And against that part, so that's the inferior cerebellar peduncle attachment to the cerebellum, and that's the bulbar nuclei 9, 10, 11, and 12. So ideally 12 would travel this way, but it's 9, 9, 10, 11 would be ideal. And again, there is a gray matter structure right attached to the fourth ventricle, and a pyramid is emerging from that anterior part. If we travel a little bit downwards, you would find a perfectly aligned anatomy here. So that's inferior cerebellar peduncle. In the front, there are two pumps. These are the pyramids. And in the middle, you may find a third pump. That's the inferior olive. So that's three pumps, ideally, inferior cerebellar peduncle, olive, inferior olive, and pyramidal tracts, and descending pyramidal tracts. And these are the fascicles of the nerves, 9. So it's difficult to identify which is which, but there's 9, 10, and 11 traveling this way, and ideally hypoglossal emerges from the front. And that's another cartoon to demonstrate that. There are three pyramidal, inferior olive, and inferior cerebellar peduncle, and bulbar nuclei, and autonomic control centers, and reticular formation. Okay, and that's the closed medulla. So that's in the closed medulla, you're still in a brain, so you still have cerebellar, and you still didn't emerge outside the foramen magnum. So you still a brain structure, but you don't see any fourth ventricle anymore, and you have the central canal here, pyramid, and pyramids. That's a closed medulla. Still a very, very last step of the closed medulla. And that's a pica. That's a posterior inferior cerebellar syndrome. I just want to outline that it involves part of the inferior cerebellar peduncle and part of the cerebellar hemisphere, sparing the rest, sparing the pyramidal fibers, and sparing the inferior olive in this case. So now this cartoon is mainly to remind you that MS lesions tends to be either disruptive to the function or even silent. So disruptive because it does not completely destruct the axons. So you still have a preserved function, but it is not working as it should be. And it can be silent because once an MS lesion is formed, it's likely to persist. One of the hallmarks of MS lesions is they continue to be there for the rest of the patient lifetime. And that's why you have a lesion that maybe happened 10 years ago, but still appears in the pons. And at that time, the patient has recovered, so it's mostly silent. And that's unlike vascular lesions and infective lesions. So they tend to be quite destructive to the tract, and they tend to be quite symptomatic. So you can merely have a silent lesion in the midbrain to an MS patient, but you would never had that without signs in a patient with a stroke. You would have a complete hemiparesis, but you would have some mild disruptive or even abnormal movement in people with MS. And here is a very nice idea have been recently working on. You know that MS lesions tends to occur around veins, and very easily you can imagine whatever part of the fourth ventricle you are seeing, all the veins emerge like the sun rays from the fourth ventricle. So all the veins arrange radially aiming to reach the subpile surface. And that's a line of the long axis of MS lesions will tend to follow that orientation. So all of them would follow that radiant that axis, that long axis of the across the brainstem, and it's very easy to think of it. So that's part that these particular scans are actually 70 gradient echo sequences, but you don't particularly need that. And with to be sure about an MS lesion, sometimes it's just to find the alignment, the long axis of the lesion orients on these lines. Well, that would be enough. So let's travel for I wouldn't go much into these details. You will find them in a dedicated video in the YouTube channel. But let's go through where usually MS lesions tends to happen. They tend to occur in the periphery, either on a cerebral peduncle that's in the brainstem, or in close attachment to the aqueduct or the fourth ventricle. So that is a lesion attached to the periaqueductal gray, again the long axis this way, and that's another periaqueductal gray, periaqueductal gray, periaqueductal gray, and they tend to be silent. These lesions does not particularly cause irritative symptoms. That part is not clinically reflected, but it tends to increase the chance of the patients getting a headache. And here's another lesion, and you can simply contemplate the long axis of lesion orientation, and there is another chip here of a silent lesion in the cerebral peduncle. In cerebral peduncle, yes. And again, it's quite numerous and quite characteristic for people with MS. But sometimes they can be symptomatic, like this patient presented with a Peyronie's syndrome. This patient presented with upbeat nystagmus, and that's another lesion in the upper midbrain occurring around the aqueduct. That's the that's the pontine midbrain junction, and that's again that's fourth ventricle, and that's a lesion orienting to one of the lines that spreads radially, and that because it affects the gray matter zone. This patient presented with eye movement abnormality, in this case upbeat nystagmus. And that's another pattern of lesion which affects that peripheral outer part of the midbrain, and they usually results in abnormal movements, chorea in this case, and that's presented with tonic spasms. And again, the long axis can be easily picked up. And this patient presented with Touretteism, bilateral lesions on the cerebral peduncles, and patient presented with pathological laughter. These very peduncular lesions, well outlined, having the long axis across the cerebral peduncle, is very characteristic of MS. And that's enough of for our purposes. It's maybe enough of the midbrain, but sometimes it involves the superior cerebellar peduncle decussations, and that's when people presenting with intermittent paroxysmal dysarthria ataxia syndrome quite easily overlooked for functional disorder, because it is intermittent. And it is intermittent because it is irritative and not destructive. So that's, again, PAD, paroxysmal ataxia dysarthria syndrome, PAD. And another case with PAD that's involving the core of the lower midbrain here. So it's again the core, which is presenting with paroxysmal ataxia syndrome. Another case report was PAD, and you notice there is a little chip of the medulla of the cerebral peduncle here, and another lesion is quite numerous, quite well reported in case reports in people with paroxysmal ataxia dysarthria in relation to a demyelinating lesion of the midbrain. That's another chip here. That's the paroxysmal kinesogenic dystonia, things that neurologists love for unknown reasons, the kinesogenic forms of dystonia. And that's another core lesion involving the center of the midbrain, paroxysmal ataxia syndrome. Now in the pons, you would have lesions that may involve the superior cerebellar peduncles. Again, the lesions around in attachment to the fourth ventricle, and lesions that follow the fascicles of the nerves, or lesions coming from the periphery, but we don't have a peduncle here, so it's just be a subpile. We will call them subpile lesions. Let's have a look through them all. But as you know, there is a very famous rule that people with vascular pathology usually involve the core of the pons, and people with MS pathology usually involves the outer part and the periphery of the cord of the pons, and that works in most of the time. So that is a very contemplative. This is a vascular pathology, small vessel disease, and that's MS pathology, periphery, and periphery. Considering that this is a core, this would be a periphery to it. Superior cerebellar peduncle, guess what? It's called cerebellar symptoms, so that makes sense. And again, subpile lesions emerging from here. And okay, and that's lesions in close proximity to the fourth ventricle. This patient presented with wall-eyed bilateral internuclear ophthalmoplegia. Again, something that us neurologists fascinated with these names, but anyway, they're not particularly relevant. That's again a fourth ventricle lesion, attached to the fourth ventricle, closer to that part of the midbrain. I call that part of the midbrain posterior paramedian. Posterior because it is in the posterior part, and paramedian because it is closer to the midline. That's where gray nuclei are in the brainstem. The rest of the brainstem is occupied by the cerebellar fibers. So that's the rest is cerebellar fibers with some fascicles and some, so there's just relations. But the gray matter stuff are always attached to the fourth ventricle, and they almost always cause eye movement abnormality. And again, that's why people with MS tend to present with, mainly when they have lesions in the brainstem, they would have eye movement abnormality and cerebellar manifestation. People with cerebrovascular disease tends to predominantly present with pyramidal interruptions. MS rarely interrupts the pyramids in the midbrain, or when it happens, it tends to be subtle and not matching the burden or the size of the lesion that is happening in the brainstem. Compared to a stroke, of course. That's a badly outlined. It's a very early case report. It's in a poor quality MRI, but it's just, again, that's one of the paramedian syndromes, and presented with abducent palsy, posterior paramedian syndrome with, again, eye movement abnormality as a group, middle, and as the downbeat nystagmus and vestibular symptoms. And that's presented with gaze palsy, that patient. And that's another patient with 8.5 syndrome. We love eponyms and names and naming syndromes in neurology. That's quite obvious. So 8.5 is 1.5 syndrome, and then plus the seventh cranial nerve. And 1.5 syndrome is a gaze palsy plus internuclear ophthalmoplegia on the other eye. And that's enough of the namings. That's internuclear ophthalmoplegia of Lutz. Reverse eye, no. Forget about it. Don't worry. You would be a perfect neurologist without this syndrome. Trigeminal fascicle syndrome. There's a fascicle is simply a line of following a vein that likely traveling with a fascicle of the trigeminal to emerge from the surface of the midbrain, and that ideally presents with trigeminal neuralgic symptoms, and that's again one of the very characteristic lesions. Tends to to occur predominantly here, and these are few subpile lesions. And if these lesions caused some cerebellar problems, you wouldn't be surprised. We know that the pyramidals are deeper here, and we wouldn't be much affected by the demyelination. And you have a nerve root entry here, which is a very characteristic lesion of MS as well. And but it's quite contemplative is how the radial appearance of these lesions all are. It's very nice and very easy to pick, actually. You don't need much training to pick it up. So that's again traveling fibers, fascicular lesions. Maybe that confluent lesion wouldn't perfectly match the radial lines I'm telling you about, but the majority of lesions, if you have too many lesions in a brainstem and they do not conform to the sun rays of the fourth ventricle, likely you're not facing an MS patient. Again, that's a patient with facial trigeminal and facial palsy. Again, that's the same manifestation. It says the case should be easy to pick now. And let's have a look into some of the brainstem lesions because they're quite peculiar. You can have the lesions around the fourth ventricle. You can have the lesions in inferior cerebellum. You can have a fascicle. You can have a pyramidal lesion. That's rare. I will show you how it happens. And there is, most importantly, and very rarely, but quite life-threatening, is to have a lesion interrupting the autonomic centers in the medulla. So that's how they should appear. This is central medullary syndrome. It causes variable autonomic syndromes because even for example, if you have a respiratory center pattern and you have a demyelination within that, so you are likely to have a disruption to the rhythm, to the central pattern generators, and that's enough to cause problems for patients, let alone if you have that for the heart rate or the blood pressure. So that's that patient with central medullary syndromes presented with a flash pulmonary edema, and that's another patient presented with stress cardiomyopathy. That's a Takotsubo cardiomyopathy, again with central lesions affecting the central medulla. That's a very early reported case with orthostatic hypotension due to a lesion in a closed medulla. But that's a poor quality MRI. For that particular lesion, that patient known to have MS, but this a very much of an acute lesion caused respiratory failure and quadriparesis. That's quite an aggressive one, and that one presented with hiccups. The one that rings a bell towards neuromyelitis optica, but no, it can still can happen in people with MS. And that the anterior pyramidal syndrome does not particularly cause weakness. They usually results in abnormal movements, as we discussed at a point. And the anterior, so that's variable, but in any case, that's a central lesion, that's an inferior cerebellar peduncle lesion, and that's another central lesion, and that's an anterior pyramidal lesion in the brainstem in people with MS. I will give you a break. I will just remind you that the lesions in the cerebral craniocervical junction, you can have a lesion from the front, and that's the pyramidal one. And that particular lesion can extend from the medulla to the upper cervical cord. However, lesions in the posterior part, the lesions that affect the posterior column of in case it is MS, they are rarely continue to travel to the fourth ventricle. So they tend to be interrupted by the start of the fourth ventricle. In contrast, people with neuromyelitis optica tends to have the lesion expanding up to the fourth ventricle at some occasions. Okay, few minutes, maybe 1 or 2 minutes break, and if you would like to ask some question about what's happened, feel free to ask it in Arabic. I can pause the English for a bit, and we can return back at another point. I'm going to maybe just in 2 minutes we would start the next spinal cord. Any questions so far؟
السلام عليكم دكتور محمد.
اهلا وسهلا. اهلا وسهلا، ازيك يا دكتور؟
شكرا على المحاضرة الرائعة، والله تسلم لنا.
بخير.
كنت عايز اسال حضرتك، يعني مثلا لو عيان في الفيرست برزنتيشن بتاعه مثلا لقينا الليجن ده في الميد برين بري اكويدكتال كده، هل ده يديني suspicious بصورة كبيرة ان انا فعلا امشي بصورة الام اس لو فيرست اتاك هو مش محقق الكرايتيريا وابدا ادور وراه، ولا هنتظر؟ ولا يعني يعني اعتقد هل ده يعني برضو ده يدخل في الديفرنشال زي ما حضرتك قلت في الفاسكولار؟ اعتقد بيعمل بنفس الشكل، يعني الويرنيكي بتعمل بنفس الشكل برضو، ممكن يبقى ليها البرزنتيشن بيري اكويدكتال ديمايلينيشن كده.
آه،
آه،
هو ليجن واحد ولا اكتر؟
لو ليجن واحد مثلا بنفس
هو لو
الشكل
هو
كده.
لو هو ليجن واحد وفي نفس المنطقه دي بس ومفيش غيره وهو ويل اوتلايند، انا مش هفكر في فاسكولار باثولوجي فقط، هبقى مور توردز نيورو انفلاماتوري عامه. ولو الليجن فضل لفتره، والفتره دي تعني مثلا 3 شهور 6 شهور، او فضل ما بيتغيرش، هفكر اكتر towards انه يكون ليه ريليشن بالام اس if at all. بس هي في الاول وفي الاخر في diagnostic criteria للام اس، احنا كلنا ماشيين عليها، فانت هتمشي عليه بنفس الطريقه يعني. فمش هتقدر تشخص ام اس من واحده بس، من ليجن واحد
من ليجن
بس،
واحد. اه
من ليجن
تمام.
واحد بس. انت ممكن لو عندك هاي سسبشن هتعمل تاب، يو ويل تاب هيز باك، هتراجع الهيستوري من البرسبكتيف بتاع الام اس تاني، تشوف دلوقتي على الكريتيريا الجديده، تبص تلاقي تعمل فيجوال ايفوك بوتنشالز او او سي بي او سي تي، وتشوف اذا كان ده هيكمل ولا لا. آم، آه،
بس انا
ده
قصدي
بخصوص.
ده لو فيرست برزنتيشن، وانا حتى شايف ان هو في المكان بتاعه وهو شكله ام اس ليجن، انا هتعامل معاه موستلي ان هو ممكن يكون ديفرنشال او كانه فاسكولار مثلا. ممكن احط سنجل انتي بليتلت، بتكلم على الكلينيكال يعني، ممكن اتعامل معاه لانه سنجل انتي بليتلت واكمل بروتوكول العادي بتاع الفاسكولار، صح كده؟ يعني قصدي لو
Uh,
جالي عيان
صح.
بالليجن
بس
ده.
بس if it is asymptomatic lesion, if it is without a symptom, I would strongly doubt the vascular pathology. Vascular pathology tends to be strongly symptomatic, and the vascular territory, when it involves the core of the brainstem, it tends to have symptoms. So it tends to so it is quite unlikely, particularly if it is silent. And the other differentials, like for example, if you're I say a neuromalacia optica MOGAD, they are quite symptomatic and they are rarely asymptomatic. And when they do happen, they tend to resolve over time. So if you had a lesion that has been there, has been silent, and continued to be there in the next months, it is one of the consistent features of MS. However, you would there is a very nice English proverb. Is called one swallow, which is a type of bird. One swallow doesn't make a summer. So you would need more evidence, but you would be more towards that. Unlike if you had a persistent deficit, persistent brainstem symptoms, and I would ideally think of an alternative. But if it is silent, I would think of MS as the most likelihood.
اه اوكي. طيب السيرفايكال مدلري، معلش، هل الشكل الفاسكولار بتاعها ايه؟ يعني انا مثلا عندي، يعني كان في كيس كده كان فيها هورنر على نفس السايت موجود، و والبرزنتيشن بتاع البيشنت كان فيه كأنه لاترال مدلري بالظبط، بس معاه هورنر، معاه الجزء بتاع السنسوري اللي هو كأنه الجاكيت افكشن، لانه هو واخد جزء السيرفايكال كأنه سباينال كورد مع الجزء المضلة كده. فمع كان فيه هورنر بالنسبة للبيشنت ده على نفس السايت، كان في جاكيت سنسوري اللي هو كان فيه افكشن للبين والتمبريتشر على السايت التاني، نفس السايت، والسايت العكس اللي هو افكشن للتاتش والحاجات دي كلها. حتى لما اتعمل لما عملنا بس يعني العيان ده حصل له ديتريوريشن سريع بصراحة كده وبلبر سيمتومز ودخل على طول انتيوبيتد، بس كان شكله كديفرنشيشن بنفس الوضع ده، وخصوصا النستجمس اللي كان فيه ابر اند ابورد اند داون وورد بيتنج نستجمس مع هوريزونتال نستجمس، فكرايتيريا ككلينيكال كده. يعني هل كجزء فاسكولار مع الديبايليتنج، يعني هل حضرتك توضحها لي اكتر يعني
Uh,
ولا؟
so there is a clear distinction between clinical vascular syndromes in the brain or medulla and the rest of the spinal cord, uh, because the pattern is hugely different, and we don't have overlap syndromes. So for example, you have medullary syndromes of vascular origin. And you have the lateral medullary syndrome, you have the Wallenberg, and you have a Jackson's syndrome, which is involved the ventral part of the or the medial part of the medulla. But no one classically described a vascular syndrome that involved medulla and spinal cord. What usually links both together is, so you have a cord syndrome plus a lower brainstem syndrome. What is They are almost always either inflammatory conditions or mechanical, like for example with Chiari malformations and cranial cervical malformations or compressive or traumatic pathologies. At that stage, you would find a clinical syndrome with hybrid between a brainstem syndrome and a spinal cord syndrome. So ideally, if I have a patient with combination, I would not refer to a classical vascular surgery. So that's by far excluded, and I would think about inflammatory pathologies until I exhaust myself. So I wouldn't think vascular in that situation, because it's a combined one. Um, it's quite interesting. I would be, if you keep the images of this patient, I would be happy if you share that with me, and we can continue on that for discussion about that further. It is a quite contemplative part of inflammatory conditions. Brainstem is always challenging in neurology practice. To so that not to disturb your sleep wake rhythm and get you to your bed easily. We didn't wait too long. I'm going to start with the second part with the code presentation in MS. And actually, if you practice 1 or 2 years in MS and in neurology in general, you would know that the criteria for and how a typical MS lesion would appear in the spinal cord is quite easy. It's peripheral in the lateral cord or in the posterior cord, and it occupies 1 or 2, maximum 2 vertebral segments, and simply that's it. So there's no too much to tell about the MS lesions in particular. However, it is always a challenge that there are a lot of things happening in the code that they are not particularly MS, and we need to be confident about um, diagnosing them and not to attribute them to MS. So most of these sizes, unlike the brainstem session, most of this session would not be about the MS. And at the very end, we'll have a couple of slides about MS, how MS lesions would do, and we will just contemplate the other patterns, the other spinal cord patterns, as we go through. But I will start with why particularly imaging the spinal cord is quite a challenge, even for tertiary centers or even for more specialized centers, even in high field scanners. If you don't have an optimized sequence to detect spinal cord problems, you are likely going to miss a lot of information. So first is the spinal cord itself is in the size of your little finger. So you're imaging a very small structure surrounded by, to count the list, water, there's a CSF, dura, and lots of fat, lots of muscle, lots of bone marrow signal, and lots of bones and ligaments. So, and all these structures tends to introduce signal noise. It's not particularly noise, but they are reflecting the inherent features of these tissues. However, the signals emitting out of that, flashes it looks like a bright light. If you're trying to take a photo, they tend to be like a source of light, blurring the details that you would like to pick. It's very difficult and very challenging unless you attenuate all the surrounding lights or bright signals from these different tissues. And it's very unlikely you would be able to nicely pick the outline of the spinal cord and its lesions. So that's one. And two, there are very, very limited patterns to think about. You have a short segment, long segment, peripheral, central. That's the whole story. So you don't have radial patterns. You don't have the nice cartoons and a nice imagery of the supratentorial brain lesions. You have a lot of, if the brain is a sketchboard, that is a wide, nice sketchboard to draw too many pathologies, to imagine too many things and too many patterns upon. The spinal cord is quite little piece of paper. So you only have very limited patterns. It's either, for example, you have that long segment, short segment, and again, it is central syndrome, peripheral syndrome. So you don't have much to say about. And that makes the diagnosis challenging because you can, so like if we have 200 conditions, 100 would be a long segment, another 100 would be a short segment, and you live with it. So it's difficult to get an answer just from a spinal cord lesion. And we spoke about the surrounding tissues as before. So it tends to that's bone marrow, CSF, dural attachments and ligaments, fat, muscles, and we need to focus into that bit. So most MRI scanners have protocols for spinal cord imaging or spine imaging, but they tend to have an all-in-one. So that's one would fit if you're looking for a wear and tear and spondylosis and in the vertebral cord, that's one pulse sequence. And but in the same time, in the same scanner from the same center, if you would like to look for an MS lesion, they will give you the same protocol you're doing to detect disc disease, which is a shame because you wouldn't take a thing. Unless you have optimized sequences, you would lose too much of the information here. And of course we put in the cervical cord, the patient can swallow, the patient can breathe, and in the thoracic cord, there is a breathing movement down there. So there are lots of motions, let alone that the patient is moves around in the scanner on its own. So there are lots of artifacts. So you need a proper MRI protocol. You need a dedicated protocol to pick up intrinsic lesions of the spinal cord. So you need to have a good signal to noise. And so on the left-hand side, that's a T2, normal T2 weighted sequence is one that would nicely pick a disc disease, for example, but is overall looks accepted in terms of spinal cord. But on the left-hand side, that's the same patient and have a signal that suppressed the fat here. So can you see, if you compare the back of the neck fat, the nuchal fat, to the nuchal fat here, so that's suppressed fat signal, and that's managed to outline a posterior subtle cord lesion, and actually that's a typical of MS lesion, and you would have missed it if you had that standard one for all sequence without stir sequence or without fat suppression sequence. Of course, sometimes for simplicity, people tend to have like the whole code into one go, which is another shame. So because if you increase the field of view, you are most likely to lower the signal to noise, and you would lower the lesion to normal tissue demarcation. So never apply that cervical dorsal lumbar. So they have a dedicated study to each region of the spinal cord. Finally, you would need to have something called high in-plane resolution. If either you had it's simply that you have too many sagittal slices with slice thicknesses narrow, or you have a higher in-plane in the transverse. So we need to look nicely and closely into the axial cuts of the brain of the spinal cord to pick if it is a lateral lesion, anterior lesion, or central lesion, for example. And also you will need to be familiar with the common artifacts. So that's a motion artifact. So that's never a lesion, and you would need to have, of course, a comprehensive knowledge of anatomy. So that's another artifact, by the way. That's called truncation artifact. That's a truncation artifact, because if you notice here, so can you see the alternating signals? Let me zoom that in. So you see there is an alternating signal between bright and dark, bright and dark, bright and dark, and the same applies, continues, and one involves the spinal cord. And that truncation artifact happens because the MRI is required to image that little piece of tissue from the too many surroundings, and the shift from solid to CSF to solid again, and then there is a burden of like high signals around from the fat. That's called sometimes that truncation artifact is called chemical shift artifact, because the tissues have contrastingly different tissues, contrastingly different components, and that frequently causes this truncation artifact. Okay, and on your left-hand side, you would have, is it a pre-contrast? That's the 1 million question. It always points itself when you see, and when you contemplate a spine MRI with contrast. Is the one on the left with contrast or without? What's your call, guys? And how do you know that's it's really tricky. The only things that I suggest, that the left one, that's the image on the left, is actually a post contrast, that the part, that little middle part on the back of each vertebrae is the combination of too many trabeculae of the bone marrow, and they end with one large vein attached to the back of the vertebrae. And this is called a basivertebral vein. Basi on the base, vertebral because it's vertebral. And if this vein if this part is hyper intense in the T1, then it is likely a post contrast. But that's a T1 post contrast without optimization, without fat suppression. That's the same uh, study with fat suppression, and you are able to see there's a little suspicious lesion on the surface of the conus here. But in the moral is that you need fat suppression even in a post contrast. You need to understand how normally a post contrast MRI would do, and how would it be if in a post contrast with fat suppression T1. And again, we spoke about the STIR versus the conventional T2. And of course, you need to have a comprehension of radiological anatomy, which is a bit challenging, but at least we would look into the intrinsic lesions for the sake of this workshop. So we have we will need to contemplate the following tissues. You will find few presentations on the YouTube channel that maybe outline that in details, and it is not particularly limited to MS. But you would need to look into the meninges. You need to look into stiff tissues, bones, and the alignment of the vertebrae, alignment of the ligament attaching the vertebrae. That's an essential skill you must have before going on to interpret an MRI study in a spinal cord. But let's have some practice, and we can apply that basic bits of anatomy. This is a patient who is 28 years old, headache and occasional double vision. What do you think? Have you spotted the problem here? You can um, you can type it, and you can simply unmute and let me know and speak it out. Is this a normal study? The problem with the brainstem? Yes, because there is a double vision, so it must be a brainstem. But what's the problem? What's the diagnosis? Um, okay, I will pick that. Yes, yes, yes. There is a tonsillar descent. So there is that part of the cerebellar tonsil. The maximum allowed part is to just at the craniocervical junction, but it tends to be pig-like and descended to the upper brainstem, to the upper spinal cord. That's a Chiari malformation. So that would spare a spinal cord tapping, which can be, yeah, I can feel your heartbeat racing, having a lumbar puncture for this lady. So that's quite worrying. And so you at least you would save the life by proxy if you did, if you just spared if you made the right interpretation and spared any further testing. Okay. And what do you think this lesion is? Does that fit into an MS lesion? Yes or no? Can this be possibly an MS lesion? Okay, brilliant. Most of you said no, and Dr. Said mentioned hemangioma, which is a brilliant pickup, because there is hypointensity mixed with hyperintensity, and this applies into the T1 and the T2 even without contrast. So that's a popcorn pattern. But most importantly, there is a red flag against the MS, which is a blood product. So that's never happens in MS lesion. So that's even if it is a peripheral lesion, small segment. So that's either hemangioma or cavernous malformation, as Dr. Yasser mentioned in the comments. You have a patient with some urine retention and radicular pain in both lower limbs. What do you think of that? Yes, there is. There are very multiple, numerous. Thank you, Dr. Yes. So there's a multiple, numerous venous or blood channels here around, and that's actually, and there is an intrinsic code signal change. But the tricky thing is to not to think of that as NMOSD or MOGAD or whatever, is the abnormal vessels running in the cerebral CSF space. So that's not a myelitis. So that's a tricky thing. That's an AV malformation, and that's why having a good interpreting skills in MS in the spinal cord does not rely much into picking the code signal change. It is into picking every single change in the whole MRI, and that's why that's an AV malformation. It's a proper AP malformation, but that's how challenging MS can be, and how tricky misdiagnosing MS can be. That's simply a vascular malformation. Okay, let's try. So that's one, and for that particular sequence, that's a normal T2, and that's there, and you can pick things much easier with fat suppression, not because it is more sensitive towards blood, or for example, but because you had the window of intensities, the possible intensities you are looking through is narrow compared to the presence of fat, because the fat has a very high signal. So you would lose much of the details and the contrast between the different tissues if you have the fat in unsuppressed in one of these sequences. Okay, that's a 70 years old man with low back pain. B symptoms. B symptoms is the B cell symptoms, actually. B cell symptoms are the night fever, loss of weight, and that's B cell symptoms is described classically in yes, excellent, in lymphoproliferative disorder. Yes, and yes, that's a hematological, quite common, and of course, if you are thinking of, for example, tuberculosis and the TB of the spine, that would be. But yeah, that's the pathology looks ugly anyway. Okay, well done, guys. Let's see. That's 19 years old lady with 2 weeks of increasing lower extremity weakness, bladder and bowel problems. What do you think? Sorry. Is it intrinsic conus lesion? There's patchy spinal cord involvement, but mainly on the lower conus, and it's more particularly involving the gray matter part of the brain of the spinal cord. That's a patient, yeah, can fit into, yeah. That's in terms of um, modern neurology practice that fits well into MOGAD with H sign, but also fits into simply that if there is a risk for that patient to have poliomyelitis, for example, that's it would essentially look the same. And the only way to distinguish is to have proper microbiological, proper immunological testing. So that's the H sign, yes, but the H sign is implying the reason I'm presenting this slide is that H sign implies gray matter involvement, something that would do in poliomyelitis, something that would do in MOG antibody disease. This very particular scan is from a patient with poliomyelitis, by the way. But the reason I'm bringing that is not to confuse you, is to tell you the message that a spinal cord on its own is not enough to postulate a final diagnosis in most cases, and you would need a supplement from fluid biomarkers. So it is tricky to jump into a diagnosis only based on spinal cord imaging. Uh, yes, nerve conduction may help, yes, but antibodies against polio may help. And antibodies against MOGAD would help. So bear in mind, if there is, for example, that particular famous sign is called H sign, some of us know well about it. It does not necessarily mean MOGAD. It can mean an infection. It can mean any gray matter pathology. So just keep your mind open. We will come to the differential as we go on the side. 60 years old male admitted with asymmetrical weakness, and this was and initially, because there was no neurology input in the hospital, they thought about that there might be something with his brain, and he was initially admitted as on a suspicion of stroke. So the onset was sudden, and he developed that as he was gardening, and on turning his neck, he felt a crack, and he just had that kind of weakness. And so initially, until they had a neurologist in the hospital, when he refuted the idea of a stroke, and they had an MRI showing that upper cord lesion. Um, Here, that looks ideally as an inflammatory lesion, but again, the clinical presentation is quite dramatic. The patient and the hero of a click was quite suspicious. So, as Dr. Roa was suggesting, yes, that it might actually be an infection, because why not? It is an anterior, and we had a post contrast after that tend to show some enhancement, which, if you're confident with your radiological knowledge, you would say that wouldn't answer if it is yes or no for a cause and function. It would have been ruled out if, for example, if you found any leptomeningeal or any vertebral pathology of enhancement, you would rule out that this might be vascular. But only if we managed to get him into a diffusion study, and this is actually a spinal cord dysfunction. Less likely, the guy had a terrible wear and tear in certain parts, and one of the radicular arteries feeding through one of the nerve root canals was compressed by an acute herniation and caused him temporary weakness, and he got improved later on. And his CSF was bland. There were no inflammatory cells, and he just simply got his symptoms recovered, and radiologically had a recovery later on. So now we are going to look into three different patterns, or let's say center pattern. So there's lesions that affect the center of the spinal cord, and lesions that affect the periphery of the spinal cord, and lesions that affect the anterior, posterior, or the can't tell. So there's lesions that are not particularly conforming to any of these. the moral and the things that I really would like you to learn is um, MRI can make a diagnosis in certain situations, can suggest possibilities in certain situations, and most of the time, alone is not enough to make a diagnosis. And it is not necessary that you saw one of those characteristic signs, H sign, bagel sign, all the eye signs. These are really fancy and catching our minds and eyes, but they're not necessarily imply a diagnosis. And that's what is tricky really about the spinal cord, is to understand the inherent limitation of spinal cord imaging and to understand how a particular diagnosis can be made. And in the most majority of the lesions that affect the spinal cord, there is no single scan that can confirm the diagnosis alone. That includes MOGAD, that includes NMOSD, that includes obviously MS, that includes vascular pathologies. So just bear that in mind, know the patterns, to widen your knowledge about the potentials and the differentials and the things that can involve the spinal cord. However, I do not recommend making a final diagnosis based on spine imaging alone. Okay, so that's center pattern. Center pattern, there are lots of things that can, this has been reported. The snake eye sign or all's eye sign, they tend to occur in certain inflammatory lesions, but also can occur with chronic compression of the spinal cord. Chronic myelopathies can tend to involve also the center pattern. Anything that have a gray matter predominant pathology can have that center pattern. So that's the famous Old's eye sign, and that can happen with inflammatory condition, but also can happen with neurodegenerative conditions. A patient with ALS may have that pattern. Why? Because he lost the pyramidal input. So there is a degenerating anterior horn cells, and this was left with signal change here. So again, you might have the antibody mediated damage to the spinal cord can affect the central part of the spinal cord. They are not particularly the old eye, but they involve the core center of the spinal cord. And NMOSD is very famous. This is a famous H sign in MOGAD, and this is a patient with poliomyelitis. Again, there's a tricky case I discussed with you about previously, and so that's a central pattern. Central pattern means gray matter involvement or watershed. The cord watershed is in a core. So if you had a cord that is compressed by vertebrae or by whatever, you might have some insufficiency. And if you have any degenerative gray matter pathology, ALS is one example, but you have a few others. You might find some central cord changes. And that's another sign, but they are all ruminating into the same concept. This is bagel sign. Bagel sign happens with let's say neurobeshet. It happens with compression. Again, happens with few inflammatory conditions. But however, I'm not a big favor of making a diagnosis. As I told you, I'm not a big favor of making a diagnosis based on a nicely drawn pattern in the spinal cord, and that's a patient with amyotrophic lateral sclerosis showing some abnormal signal. And that's a can't tell sign, but it is very relevant to animals. These called the bright spotty lesions, that they have a signal, a large lesion with patchy, hyper intense, and other less hyper intense lesions in the spinal cord. That's called a bright spot pattern. That's another bright spot pattern, but happens in guess what, in neuropsychosis. So you wouldn't make a diagnosis of NMOSD based on that, based on the pattern without the antibody. And that's let's talk a little bit about the peripheral pattern. Peripheral pattern are lesions that affect the outside part of the spinal cord. So that's a T1 post-contrast, and the lesion is encroaching from the subpial surface. And that's a neuropsychoid patient. The tricky thing here, if you did not perform a post-contrast sparing the harming contrast to the kidneys of the patients, you would lose a significant diagnosis here, because that's all what it takes on the T1 pre or T1. So that's the T1 pre post-contrast and a T1 and a conventional T1. If you did not perform a proper post-contrast T1, you would lose much of the subpile pathology. And that's another neuropsychoid patient. And that's neuropsychoid because we love neuropsychoid. And that's for some reason during preparation of this slide I brought much more of these studies, these lesions, but they are all neuropsychosis. Okay, I will jump over these too many granulomas, but there is one particular pattern from the peripheral pattern here. So that's a post contrast, and that's the conventional T2. But on the axial cuts, particularly, this is a post contrast. Neuropsychoid tends because it is mainly a subpile pathology. It tends to involve the pile matter and the median sulcus on the posterior surface. So it tends to show itself as a trident sign. That's a famous trident sign of neuropsychoid. And that's a patient with syphilis actually, but it involves the peripheral part, but the posterior part of the spinal cord. And yeah, that's the same patient, tabes dorsalis, as just involving the posterior part. If you have a quite striking abnormality on the clinical encounter, and you have just these couple of lesions on the posterior part of the spinal cord, you wouldn't think of that pathology. Dr. Yasser was asking, can T2 be totally free in the sarcoid? It depends on weighting, and it depends on the sequence and the time. Yeah, technically you can have one. Yes. Yeah, it depends. It depends on too many factors, but if it can happen, yes, it can. Okay. What do you think of that? What's the diagnosis here? That's another posterior pattern. Can you see one of the famous signs in neuroradiology textbooks? That's an excellent anchor. That's subacute combined degeneration, and that's an inverted V sign. It's not present everywhere, but in some places of the world, you had people who fancy inhaling the nitrous oxide balloon gas, and and it tends to disrupt the B12 pathway and cause acute subacute combined degeneration. Tends to happen in the young population. Okay. Simply after seeing all that kind of, owls and snakes and beagles and the two different sides, the moral is that they look fancy, they look nice, they are not diagnostic. You need to know how to make a diagnosis. If you need to diagnose a B12 deficiency, you would need to demonstrate a low B12 or an MMA level that is low. If you need to make a diagnosis of neuropsychosis, that's a tissue-based diagnosis. If you would look for a lymph node biopsy and demonstrate the sarcoid pattern, if you need to diagnose a tabes dorsalis, you have the syphilis serology to confirm that. If you need to make a diagnosis of a MOGAD, you need to demonstrate an MLG antibody positivity. Images would support your call, would direct you. For example, if you are anticipating a MOGAD and suddenly you're facing a dural enhancement, so then it is never a MOGAD. So the moral that images can direct your attention, but they cannot be relied upon alone. Finally, we'll just have a quick look into how MS lesions would look like. It's quite simple. They are peripheral in the outer side of the cord. That's peripheral and anterior, and that's another lateral cord lesion, and the lateral cord lesion, and they are usually a short segment. Even if they are confluent, they tend to be interrupted with a maximum of two segments. I wouldn't speak much about them because they are quite easy to pick, and the mites, the most important encounter, particularly for the MS, is that they show a typical clinical appearance along with the spinal cord appearance, because usually spinal cord lesions, particularly acute ones in MS, they are almost always symptomatic. There has been reported few asymptomatic, but they have been the exception. But spinal cord lesions tends to be symptomatic. They can be swollen initially, like for example, these couple of lesions are swollen, but they tend to regress and resort to that size. And usually this edema would disappear over time, and you would end up with typical short segments of MRI abnormalities. And just to fancy everything in this scan, so you'd have another lesion down here, and you would have lesions attached to the fourth ventricles that they are quite subtle, but they are definitely there. So this patient is likely have an extensive supratentorial compartment as well. And with that, I finish and let you go and have some sleep. I know that most of us are from Egypt, and it's quite late already. Of course, if you have any questions or any thoughts to discuss, I'm around for the next minutes as well.